So while I'm waiting for that, I'll just say thank you very much for inviting me. I'm actually based at Newcastle University, and one of my roles there is as Director of the NIHR, the National Institute for Health Research, Healthy Ageing Policy Research Unit. So we're in our second 5-year funded term of a collaboration. So we're a group of researchers from Newcastle, Manchester and the London School of Economics. And we're commissioned to do independent research that informs English policy teams. And today, most of what I'm going to, the findings I'm going to talk about are either findings from the team within the Policy Research Unit or within Newcastle. No, not yet. I'll keep going. so my plan today is to, I'm going to briefly present some findings at a fairly high level from work that we've been doing within the unit on frailty and loneliness and social isolation. Both of these are highly socially patterned and they affect people's ability to live independently. And I'm going to make the case that actually we need to be focusing, very much like Francesco, on the quality of people's lives, not just on the length.
It works out there.
Good. Okay. Okay. That's fine. Anyway. So I gratefully acknowledge my funding, but take full responsibility for my talk today.
Lo vediamo lì, no, qui non si vede.
Okay, thank you. So in our research, we tend to, I'm also a medical doctor, we tend to focus on frailty, disability, multiple long-term conditions. But arguably, dependency is, for the individual older person, a much more important component. And for the purpose of this talk, I mean dependency to be that need for help with everyday, day-to-day activities that we all need to do to live independently. And this frames very well with the WHO Healthy Ageing framework that Francesco mentioned about intrinsic capacity and functional ability. No one wants to feel that they need help with support. No one can imagine that that's going to be the case in later life. And the resulting need for social care, the cost to society, make this one of the most important challenges. But also, I think, one of the most important influences on how well we live as we age. And fortunately, it's an increasingly significant factor within recent English health policy. The treatment to prevention shift and the focus on helping people to remain independent for longer that we have in recent policy documents is really welcome. So I'll just start with some UK context. So up until 2008, life expectancy was increasing rapidly. From around, in the UK, from around 2011, life expectancy started to fall and healthy life years dropped dramatically. And so that led to a gradual reduction in the proportion of remaining life lived healthily. If we look at, an English woman aged 65 could now expect to live between 19 and 21 years. Now that's 20 years longer than her great-grandmother, so by any measure, a good public health success. But if we think about whether those lives are lived healthily, the woman from the most disadvantaged quintile, so the bottom 10%, may expect around 4 years of healthy life, whereas at the top of the top 10%, that would be 11 years. And if we look at disability-free years, then on average, the differences between rich and poor are around 15 years. So some of our most recent research has looked at the age at which, in disadvantaged areas, people reach the age where half of their remaining life is spent with disability. And for men and women, that's 11 and 12 years earlier than the least disadvantaged, and that's based on modelling of the data from the English Longitudinal Study of Ageing. So gains in years of life have been shared across the social spectrum, but gains in healthy years have not, however that's measured, whichever metric we choose. So this bar chart just illustrates for women the healthy life years at birth in EU and UK women between 2008 and 2016, ranked by 2008 values. And actually we see that in 2008 women, the healthy years were ranked third within the EU 28, but by 2016 they'd fell to the 14, and they'd lost over 3 years of healthy years. And for men, a similar picture, they were ranked fourth and they fell to a rank of 11. So this slide provides a visual illustration of some of our findings from our frailty work, and around 8% of English adults aged 50 and over are frail, and that rises to 41% in the adults aged over 90. But there's a fourfold variation between English local authorities, with levels highest in coastal and urban areas. So at age 50, the wealthiest expect more than 10 years of frailty-free years than the poorest, and that gap, when we take into account wealth and area deprivation, actually rises to 15 years. So as well as the epidemiology, we've also looked at other issues such as end-of-life care and tools to identify younger people with frailty. But I'll just draw your attention to some work we did on COVID-19 vaccine rollout. And here we found that doses per frail person varied by a factor of 4. And that was, we think, because it was based on age and not population risk. So I think that's a really important learning for implementation of future prevention programmes. So I'll just move now to talk about what might seem like a separate issue, but I'll be drawing them together later. So again, COVID-19 brought an increased focus on loneliness and isolation and the adverse consequences for health. The best known review, which pools single study evidence, suggests that a 25 to 30% increase in mortality risk. And various other systematic reviews have gone on to describe increased risk for incident dementia, cognitive decline, and our own work described a quite significant increase in cardiovascular risk. So in the media and more generally in the UK, I think there's long been a suggestion that older people, loneliness is a factor of life in later life, and actually as a result of that they use more health and social care services. We certainly know that in terms of risk factors, older age is a risk factor, and we did a meta-analysis of 28 studies from 28 high-income countries and found a pooled point prevalence of 28.5%. There are gender differences, with women being more likely to experience loneliness and men's social isolation. Poverty as risk factor for loneliness and isolation, which is easy to understand if you lack the resources to participate in wider society. And unpaid carers, they lack the resource of time often and become isolated as a result. Evidence on minority ethnic groups is weaker, but there's a suggestion that there may be an increased risk there. However, when we come to look at service use, I think the data, our systematic review is a little old now, but I think it still stands. There was evidence for that weaker social networks were associated with higher numbers of readmissions to hospital and increased emergency department attendances. When we looked at ambulatory care or primary care contacts, the evidence was equivocal. And separate analysis of English longitudinal study of ageing data has shown loneliness to be an independent risk factor for care home entry, so institutionalisation. So whilst the data is weak in this area because it's fraught with measurement difficulties, there's a debate over the definitions of loneliness. There are established measures now, but we rely on studies that are often cross-sectional, so they give us a snapshot in time, or the longitudinal studies maybe capture data every 2 years. And so we're missing the trajectory and the fluctuation within loneliness and isolation that's a natural factor of life. I think nevertheless, there's a sufficient weight of evidence to accept that A, it's unpleasant for the individuals, but B, that it has adverse health consequences. And whatever the details of the system burden, there's certainly an influence on use of services. So with that in mind, I'm arguing that we should take a broader perspective on frailty. We know lonely older adults show faster frailty progression. Bereavement really produces a step change in frailty risk, and shrinking social networks are also a factor, and we know that social isolation does predict mortality. So frailty should be viewed as part of the older person's social system and not just a clinical concept. It's bigger than just a loss of physiological reserve. So with that in mind, I'm just going to mention a piece of work that's ongoing. A group of us, led by Martin Webber at the University of York, are working together to try and produce a tool that actually introduces the social into frailty. Frailty does tend to be a clinical concept. It's recorded in healthcare records within the UK, but the professionals who are caring for people in their homes or in their care homes don't share the language of frailty, and they don't share records. So they are dealing with the day-to-day reality of frailty, but they can't. They don't have the tools to convey that and to share it with the healthcare sector. So we're currently developing a measure, and our aim is to develop a brief screening tool with a longer assessment tool. It's co-designed with people with lived experiences and a practitioner advisory group. We've done a two-stage Delphi process, we're doing cognitive interviews, and we're also modelling the ability of the tool to predict adverse outcomes within the English longitudinal study of ageing. So it's ongoing work, and ultimately what we're really trying to do is develop something that will become part of everyday practice across health and social care. So just to take stock, because obviously I'm arguing that frailty is really important for healthy longevity, and I think we would say that we have a reasonable grasp of the epidemiology. We know what the risks are. We know to some extent where people are located. We know a reasonable amount that frailty is to a certain extent reversible. This prospective analysis, again, of ELSA participants found that 15% of frail older adults achieved remission. And I think most importantly, their falls risk fell to near robust levels, which is clearly reducing a very important risk factor. And we've also got good evidence for some effective interventions. So we have just been looking at the evidence for intervening to prevent, ameliorate or manage frailty, and this is for the Department of Health and Social Care. So this is a pictorial summary of our findings. It's a vast evidence base, even with restricting it to highly frailty relevant studies, and we had 103 systematic reviews. And the headline findings really are that preventing frailty exercise, physical activity with resistance training, and for managing frailty then a holistic, multi-component, comprehensive geriatric assessment type intervention with a regular medication review and a nutrition and a physical activity component. We know that they work. And the active ingredient is the integration and the regular review, not a single component. I think that's a really important point. So, this is my final slide, and it's a very personal view. And I come from a perspective of a primary care and public health doctor who works in research. And I think there are very many different ways in which we can enhance the years lived and age healthily. But I think today I'm arguing that actually we should intervene on frailty because it's such a driver of dependency, and those sorts of policies could have a profound effect on older people's experiences, and they would be popular. But that we should adopt a very holistic approach, and we should incorporate the social and the clinical together. So social frailty is something that I think should be enter into our rhetoric, and we need to consider people's social circumstances and where they are socially isolated or supported by their communities. Thirdly, I think we need to build the evidence base where it's most needed, and our reviews showed that actually what we were missing was hard metrics in many cases, so very little economic data, data on hospital admissions and the things that will drive costs up, but also very little data from disadvantaged communities, care homes, end-of-life care, and that's where frailty and dependency is manifest. And finally, I think we know a lot, and actually in order to enhance our later years, there are lots of things that we already have good evidence for that we could be implementing. So we need to be implementing what we know to work, to do it in an equity-focused way, evaluate robustly, capture those important data, and actually that could be far more transformational than doing that yet other study. So I'll just end by saying thank you very much, but also to acknowledge the team. This is very much a team approach, and my colleagues at Newcastle. Especially, I really want to note some of the analysts where I've given a headline finding which overlies some very time-consuming and complex analytical work. Thank you.